Okay, Dr. Thomas Wright is a board certified physician who has specialized in venous and lymphatic medicine for over 20 years. Dr. Wright brings a multidisciplinary, comprehensive approach to treating causes of edema, and his research and practice focuses on lipedema and related fat disorders and venous insufficiency. Dr. Wright has a specialized skill set and passion for unique types of liposuction and its derivative surgical procedures such as lipedema reduction surgery, fat transfer, and minimally invasive skin tightening. He was trained in tumescence liposuction technique by its originator, Dr. Jeffrey Klein, and additionally, he trained with several European surgeons on a specialized form of lymph-sparing liposuction for the treatment of lipedema. Dr. Wright has performed thousands of tumescent liposuction procedures for cosmetic and lipedema patients, and he has developed his own lymphatic sparing surgical technique using microcannulas to limit unnecessary injury to the lymphatic during tumescent liposuction. Dr. Wright has published studies on the safety of tumescent anesthesia and is used during liposuction and venous ablations. Thank you, Dr. Wright.
Thank you very much for that lovely introduction. I'm going to go ahead and jump right in. But I also want to thank the NLM people for allowing me to present, and it's a wonderful conference. So I have received compensation from MicroAir, and I do use the MicroAir product in my surgery. Learning objectives talk about the identify mobility restrictions that can occur with lipedema, and the ability how the mobility restrictions are linked to future disability and even life expectancy. So this is my disclosure side that I spoke of. The learning objectives I just was covered that about mobility restrictions can occur with lipedema, and those can affect future disability and life expectancy. And lipedema reduction surgery can improve mobility. So what is lipedema? So it's a progressive connective tissue disease that affects subcutaneous adipose tissue. It causes pain, tenderness, and untreated, it can, or untreated or poorly treated, can lead to disability or lymphatic impairment. So the diagnosis of lipedema, I know Courtney touched on this, actually did a great job, but it is a sort of patient, there's a very specific history, onset usually after hormonal change, and then there's a detailed physical exam that's really focused. It's different from other exams, and it's focused specifically for a specific derm exam to elicit the lipedema signs. And then we also rule out competing diagnoses. Obviously, venous insufficiency, obesity, and lymphedema can cause similar presentations that look like lipedema. So, as Courtney mentioned, we inspect for symmetry and proportion, inspect the skin for bruising. There's a palpation of nodules and tenderness. Dr. Hucho touched on how that's important. And then evaluate for type of edema. So non-pitting edema was present often in lipedema. Check for Stemmer sign, and check for gait abnormalities and knee range of motion are also part of my exam for lipedema. I just want to point out, the Bjork or bow tie test, which is is an excellent test for non-pitting edema, and again, unlike the pitting where you have the indentation, and normal skin will crinkle or create a bow tie, and when there is non-pitting edema, you're unable to get that bow tie. So ankle ankle cuffs and wrist cuffs are commonly, but not necessarily seen in lipedema. But that they can be tip-offs. And then lobules, and you can see here knee and arm lobules, and a lateral hip lobule, are seen in later stage 3 lipedema. There are 3 stages of lipedema. So stage 1, skin is smooth. Stage 2, it becomes nodular, and then stage 3, in addition to the nodule, the visible nodules. So stage 3 is the appearance is smooth, but you may feel small nodules. Stage 2, the nodules are bigger and they are visible in the subcutaneous tissue. And then in stage 3, you see frank lobules or extrusions of tissue that go beyond normal symmetrical borders. So there is no stage 4, though I know there have been some attempts initially there was 3 stages, then there was some attempts in the literature for stage 4, but they've been largely abandoned. So lymphatic impairment can occur at any stage. By stage 3, 60% of women have a lymphatic impairment. And again, the stages refer to a phenotype or an appearance of the skin. And lipolymphedema, which is a complication of lipedema, is really not another phenotype. It's just it is a development of a second condition. And so stage 4, so using stage 4 masks the diagnosis of lymphedema from other causes, such as venous obesity, and so that's my little thing. So lipedema treatment. So lipedema should be treated it's a systemic disease, and it needs to be treated comprehensively. So that's it can't be just treated with surgery. There have to be the conservative, non-surgical managements and treatments, including medical grade compression, a low processed, low refined called diet. Those are crucial, need to be implemented and maintained, implemented before surgery and maintained after surgery. And then other things that are also helpful, and I'll go into those a little bit in a second. But lipedema reduction surgery may be considered when the symptoms are not controlled by conservative management. But this lipedema should not be just treated as a surgical disease. So, as I mentioned, so the anti-inflammatory diet, which is anti-inflammatory, essentially low processed foods, and medical grade compression, decongestive therapy, home exercise program, and weight loss all can help the lipedema, and they not only lead to reduced pain, increase and a decrease in circumference size, but they have not been shown to improve mobility, knee mechanics, or overall quality of life. So the 6 parts of lipedema reduction surgery. So mapping of the venous and principal lymphatic structures in the leg, marking the area, administering tumescent anesthesia, the suction aspiration, manual extraction of fibrous lipodenum nodules that remain after the liposuction, and that's not always done, but can be done, and then donning with compression. So lipedema reduction surgery is a derivative of liposuction, but it's different from liposuction. Liposuction is a cosmetic procedure, and its goal is aesthetic or improvement of cosmetic appearance. Lipedema reduction surgery focuses on maximal debulking of the subcutaneous adipose tissue and also removing fibrous tissue. It's focused on functional gains and not cosmetic results. And then there are special techniques, the longitudinal cannula strokes, to avoid injury to principal lymphatic collectors. So this lymph sparing technique, or the techniques that I use, and really were validated by the German surgeons. They're principally dermatologists. But Eric Brenner, who's an anatomist, and Hoffman by his boss, Baumeister, who are also dermatologists, they did studies, anatomic studies, cadaver studies, lymphatic dye studies, and lymphocinograms to validate that they were not injuring these principal lymphatics. Over here, you can see this is an ICG study in showing where the principal lymphatic collectors run along the legs, these are the ones that we in our technique we try and not transect or run parallel to. So this is the paper I published a year or two ago, and it actually just got an award. So this showed that it improved pain, mobility, this reduction surgery, mobility, physical function, quality of life. So that was in plastic and reconstructive surgery. So it was the first to look at the lipedema reduction surgery in the United States, first to document knee joint improvement and gait improvement from lipedema reduction surgery, correlated patient reported outcomes with objective physical measurements, show improvement in mobility and measurements that correlate with future disability and life expectancy. And so the thoughts behind this was that I looked at the orthopedic literature because we know that lipedema affects mobility, and so I looked at the orthopedic and how did they measure and show impairment to mobility and knee joints, and so I looked. So they use goniometers and other mobility measurements, so we incorporated those into our practice to follow for our lipedema patients, and then we used the PROMIS mobile. We used the SF-36 quality of life and PROMIS mobility outcomes. Also then looked at so we looked at all these, and these same measurements have been used in following total knee replacements. So here's this goniometer I was speaking of, and we just measured the so here you're measuring the angulation of the leg. So a normal leg would be completely straight up and down, and there's a valgus angulation at the knee here in this lady with lipedema. And then here's measuring knee flexion with the long arm goniometer. This is where she is in red, and you can see how the lipedema tissue here in the back of the calf and in the thigh are inhibiting or preventing her from getting her normal normal full range, full flexion of her knee. And so we looked at those measures and followed them. And so before surgery, there was a significant limitation. Normal is around for a normal person is around 135 and knee flexion. And our lipedema ladies started at the average was 120 degrees was the average knee flexion, and then they improved about 6 or 8 degrees after reduction surgery, measured about 6 weeks to 6 months after surgery. That was both in the left and right knees, is similar improvements. There was also an improvement in the angulation or how straight their leg was, about 3 degrees improvement in left and right knee. And then the Q angle was not significantly changed. Measuring their gait, 80% had an abnormal gait prior to surgery, and that reversed after surgery. Only 20% had an abnormal gait and 80% had a normal gait. So how does this knee flexion, how is that going to affect mobility? Well, if you need 135 degrees of knee flexion to get in and out of a car without difficulty. And so if you're down around 120, you're going to have trouble. But if you get that improvement that we saw, they're much more easily to get in and out of a car, up and down, and stair descents. If you had even so, the average was 120, but if you were we had some women who only had 105 degrees prior to the surgery. And actually the ones who had the most impairments got the most improvement. So now this is their overall mobility score. So PROMIS is a tool developed by the NIH, and it's been validated to the normalized to the US population. So 50% would be the normal average mobility of someone in the US. And we saw here that on our mobility rating for lipedema patients before surgery was 35 and improved almost to 45 roughly. And this was highly significant. This is about twofold kind of two to threefold increase you see with actually a total knee replacement. Patients reported a 16% ability to walk at a normal speed. And so these ability to walk at a normal speed is that is actually linked not to life expectancy or future disability. So at least the average improvement would mean they were less likely to develop disability later in life, or even potentially live longer. Similarly, a 16% improvement in the ability to go up and down stairs, and a 27% improvement in the ability to run a short distance. And a 12% improvement in the ability to stand for an hour. So we also, as I mentioned, we also looked at the SF-36, which is commonly used in research, both in all types of clinical research, but also in orthopedic research. And there's 8 domains of physical of health, and those include physical function, role limitations, energy and fatigue, emotional well-being, social functioning, pain, and general health. And we saw statistically significant improvements in all of the domains, and these are also comparable to that which see with a total knee replacement. So there was a 12.5% decrease in overall body pain, a 12% increase in overall health, an 11% increase in the ability to handle activities of daily living, and a 13% increased ability to complete normal tasks, and a 10% increase in ability to complete normal tasks limited by emotional abilities. So we also looked at lobules. So I showed pictures of lobules at the beginning, and so the percent. This is in stage 3. Obviously, lobules are seen only in stage 3, and so this is looking at just the stage 3 lipedema patients, and prior to surgery, close to 90% had lobules in their thigh, and only a small percent had them after surgery. The inner and lateral, inner would be the most common, lateral would be the second most common thigh lobules. At the knee, there was about 55% who had it before, and that decreased significantly. And upper arm lobules also significantly decreased. So this is an example of an arm lobule before on the bottom, and then after on the top. Similarly, you can see here there's a knee lobule on the inner knee, and after surgery, it resolved. So it's possible, the stages are descriptive of the tissue, so it's possible then you could argue that if they had lobules before surgery, and then they had no lobules after the surgery, they would go from stage 3 to stage 2. This is just a picture of overall changes seen after several lipedema surgeries. So complications. So again, this is different from cosmetic liposuction, but some of the complications are very similar to. The unique sort of complications is it's a larger volume because we're going for maximum debulking to get the mobility improvements, and so there is a possible increased risk of blood loss. We looked at blood loss, and a small percentage did drop their hemoglobin, though no one needed blood transfusions or anything like that. It was just a drop. Lightheadedness is very common with both cosmetic and postoperative lightheadedness is very common with both cosmetic and lipedema reductions. Now, we didn't have a great deal of blood loss, and part of that is I believe that treating the varicose vein, if there are large varicose veins present, I believe it's important to treat them preoperatively, because they can lead to increased bleeding postoperatively if they are present in the lipedema patient. Now, women with lipedema have an increased risk of DVT. And then also that's just because of the lipedema, even matched for their BMI. But if they do have, we do prophylactically put them on blood thinners to if they have significant risks, and so we do think that that's important, especially in our lipedema patients. And then lymphatic injury can occur as part of this. Is we know that there's lymphatic abnormalities. Have women with lipedema have a greater risk for developing lymphedema. So we want to take extra care in that. And this is just from a study I published a few years back on some case reports of lymphatic injury that occurred in lipedema. This lady, this 38-year-old woman, had a light surgery on her, had a lipedema reduction on her thigh, and post-operatively developed, as you can see, swelling in her right foot, and you can see here, she had a positive stemmers. It's just in this one leg, and then this is a lymphocytogram which showed decreased uptake of the radioactive trocer in that right leg, and this is the anterior and posterior views. And so this is 30 and 90 minutes are the time frames on them. Well, thank you so much for the ability to present, and thank you for your attention. I'm going to leave you with this quote. Never doubt a small group of thoughtful, committed individuals can change the world. In fact, that's the only thing that ever has.
Great. Thank you so much, Dr. Wright. It's a really insightful presentation. So thank you. So we do have a number of questions here for you, and unfortunately we're not going to be able to get through them all today. There's numerous, but we will start with a few. So, is the disease of lipedema causative for the joint pain / inflammation, or are the joint problems due to the extra weight that the joints need to carry, just as an obese patient who does not have lipedema may have NEOA?
Wow, that's great. I don't believe lipedema itself causes arthritis, but it does. But the extra tissue puts extra stress on the joints. Now, it's not just from the weight, but it's also because the accumulation, the bulk accumulation around the joints, and the deviation from normal angulation puts extra stress on the medial part of the knee joint, just from the lobules in the hips and inner thigh. So that does, and intuitively that would accelerate the progression or development of arthritis in the joints. And then there is also, I mean, obviously, if one is heavier, that also plays a role too. So those are both both positive factors in the development of arthritis. And we did see an increased prevalence of arthritis in our lipedema patients, much higher than would be expected, even from the general population, or even obese population.
If a person with lipedema undergoes liposuction or other fat removal surgical interventions, do dieting or bariatric surgeries help to prevent recurrence?
I believe they will, but that's not proven. But I believe very strongly that they should be maintained, and I feel that there, as Courtney mentioned, there can be, I feel that it's very important to prevent that, and so all the conservative measures really should be very strongly implemented before and continued after.
Do you use ICG?
I do. I published a small paper on ICG in lipedema.
Okay. What is your post-operative recommendation for compression garments? And the second part was about ICG. So
Yeah. So I we generally 20 to 30 pantyhose. I really feel like the problem post-operatively, we don't want a gathering at the knee if they have the layered knee high in capri. We really prefer the pantyhose. Now minimum of 20, 30, we'll do that on the thighs. After doing the ankles and calves, we often use 30 to 40. And sometimes we'll also add even additional compression. I'm very pro compression. and,
we like compression
and,
too.
and we really encourage use of pump and MLD afterwards as well. And yeah, they all go together.
Great. Do you have a BMI restriction for your surgical patients?
I do. I limit to patients under 50 BMI.
Okay. Someone is saying, playing devil's advocate here, wouldn't liposuction also help women with simple obesity increase knee flexion? So not unique to patients with lipedema, as both have increased tissue at the knee that decreases knee flexion.
I think that's a great point. But the issue is that the disproportionate accumulation of tissue in lipedema around the knee joint is going to but certainly you can get increased tissue from simple obesity, just not in the same proportion.
Okay. Well, let's see. Given that the surgical approach aims to avoid lymph collectors, yet a significant portion of the lymphatic system remains unseen, is there an increased incidence of lymphedema following lipedema reduction surgery?
So I can't say that there for sure that there's an increased. In fact, there's no. I think lymphatic injury is a rare thing, and not it's a potential and rare thing, but not something seen regularly. But I do believe that extra care should be taken to not cause any further damage to lymphatics. And I want to just say that this I believe also that I want to be clear that liposuction, lipedema reduction surgery is interrupting all the lymphatic capillaries, many of the collectors, and that is, and we feel that certainly it's just my belief is that as long as there's just the very few most important major lymphatic collectors are that run along the fascia, kind of parallel to the saphenous, that as long as those are not interrupted, I feel like lipedema and patients without lipedema will recover and have normal lymphatic function. In fact, there's even a few studies like Chantal van de Pas in the Netherlands show it may actually improve lymphatic function, the reduction surgery.
Could you speak a little bit about pre-op recommendations to prepare for the clinicians to prepare patients better for surgery? This person says, because I often hear the expectation that the surgery will cure their lipedema. They don't plan to wear compression or use anti-inflammatory diet, etc. after surgery.
I mean, I just hate to hear that because first of all, why is it so important that they started beforehand? Because people will incorporate that. I mean, they have to be able to tolerate their compression. The worst thing that could ever happen would be to do the surgery, which causes increased swelling, and then not be compliant or be able to tolerate the compression. So that is second. I mean, the dietary. This again, as we've said, this does not. There's no cure for it. The dietary, it can be helped as other people with a low refined carb diet, what we call our anti-inflammatory diet, perhaps even a super low carb, high fat diet, as was mentioned earlier. All those can be helpful, but the timing of that needs to be that they need to be instituted before they do surgery, because first of all, they're going to be they're going to be able to appreciate the effectiveness of that. And when you get sort of a honeymoon period right after surgery, when the tissue has been reduced, and they may falsely assume that they have some sort of cure or it's gone. That's just not true. And we feel that that maintaining that will make them much less likely to have progression or reaccumulate.
Okay, and again, there's lots of questions. I'm sorry we can't get to them all, but one of a common question that seems to be brought up right now is, do you have a post-op surgical protocol?
Yes. I mean, we have, again, we have them in 24/7 compression, except for when they're showering, etc. For 2 months. I already kind of spoke on the compression strength. We have them. We usually don't have them resume MLD till they're not draining, which is usually going to be can be a week. I mean, it can be a little shorter or a little longer. We have them start using. I mean, if they have a pump, they can use that. If they like when they're first draining, we have them put their leg in a trash bag and that sort of thing. And it takes about a month to recover from one of these surgeries. So we have them, be careful, but gradually increase their activities for that. No, nothing in the pool until all the wounds are closed. The adducts, there's little kind of 2 to 3 millimeter adducts, and they heal by secondary intention. And they that can take, a few weeks to heal. So.
Great. Well, thank you so much again for being here today and presenting. We really appreciate it.
Oh yeah, what a pleasure. And what a great conference. Thank you so much for the opportunity.
Thank you.